Have you ever felt like just a number in the healthcare system? Or just looked at a medical bill and thought, how can it possibly cost this much?
It's a feeling a lot of people share, I think.
Absolutely. And while we all want better care, maybe care that feels more personal, more effective, well, there's actually a framework out there designed to get us there.
Mm.
All right, let's unpack this a bit. Imagine a healthcare system where you genuinely feel looked after, where, your whole community is getting healthier, and where the costs aren't just constantly, relentlessly going up.
Sounds pretty good, right? Almost too good to be true, maybe.
It really does. Well, today we're doing a deep dive into a concept well, it's been around for a little while, but honestly, it feels more relevant than ever. It's called the triple aim in healthcare.
Right.
And it's this really powerful idea that says we can, and actually we must, improve the care experience, the population's health, and the cost all at the same time.
Yeah, and this isn't just, a theory someone cooked up. It's a framework proposed by real experts in healthcare improvement. We're drawing heavily today from the work, excerpts from Berwick 20 Care, 20 Health, 20 and 20 Cost.pdf by Donald Berwick, Thomas Nolan, and John Whittington.
Okay.
And what's fascinating, what they really assert, is that the hurdles we still face in getting truly integrated care, well, they aren't technical anymore. They're political.
Political.
So, yeah, this deep dive will explore what this triple aim actually is, why it's considered so vital, what's standing in its way, and, what real solutions might look like based on their work.
Right, because the challenges, they feel huge, often kind of abstract.
Yeah.
But the source, it gives us this really concrete example that, for me, really hits home: congestive heart failure, CHF.
Ah, yes, CHF.
Apparently, it's the single most common reason Medicare patients end up in the hospital.
That's right.
And here's the really tough part. 40%, nearly half of those patients are readmitted within just 90 days.
It's a staggering number.
It is. But then here's the kicker, the really astonishing part. There are well-designed projects out there that have shown this readmission rate can be reduced by over 80% just with proper management.
80%.
Yeah.
That's incredible potential.
Incredible. And what I found really striking when reading the source was exactly that paradox. If we know how to do this, how to drastically cut these readmissions, why isn't it happening everywhere? That just kept bothering me.
It's the central question, isn't it?
Yeah. The source describes the current situation as a system providing poor service and lacking memory. And what that means for you as a patient, or maybe if you're caring for someone, is just constant frustration. Having to re-explain your whole medical history every single time you see a different doctor, sometimes even within the same hospital system. That lack of memory is it's a fundamental barrier.
It really is. And it's not just CHF, of course. That's just a prime example of a system that just doesn't have the capacity, really, to integrate its work over time and across different places. People get care clinics, hospitals, home care.
Right. It's all siloed.
Exactly. And if we connect this to the bigger picture, there's this U.S. health system scorecard that the source mentions from the Commonwealth Fund Commission. It painted a pretty stark picture.
Oh, how so?
Well, it gave the U.S. healthcare system an overall score of just 66%. 66. And this is despite us spending nearly double what the next most costly nation spends.
Wow. Double. And still only a 66.
Yeah. And we rank poorly on key health outcomes because of it. We're talking 31st in the world for life expectancy, 36th on infant mortality, 28th for male healthy life expectancy, 29th for female healthy life expectancy. The results just aren't matching the investment.
It's so brown.
It is. And the source highlights another critical side effect of this huge cost burden. The U.S. remains the only industrialized nation that doesn't guarantee universal health insurance. The argument you often hear is, well, we just can't afford it. And a lot of the current efforts to improve things, they tend to focus on just one place, like fixing things within a single hospital or improving one clinic.
Right, like optimizing just one part of the machine.
Exactly. But that misses the crucial continuum of care, especially for people with chronic conditions who need coordination across many settings over time. And that fragmented approach, well, it leads to really slow progress.
Which is why we need something like the triple aim, I guess.
Precisely.
Yeah.
It offers a different way to think about it.
Okay, so given all that context, the fragmentation, the cost, the poor outcomes, despite the spending, what exactly is this triple aim trying to achieve? What are the core goals?
So the framework lays out three really clear interdependent goals. They have to work together.
Okay.
First, improving the individual experience of care, making it better for you, the patient.
Makes sense. What's second?
Second, improving the health of populations. Not just individuals, but the overall health of a defined group of people.
Okay, so broader than just one patient visit.
Much broader. And third, reducing the per capita costs of care for those populations. So lowering the average cost per person.
Experience, population health, and cost. Got it. But interdependent, you said?
Yes, that's key. They're not separate aims you can tackle one by one. The source points out, for example, that improving care could raise costs, maybe if you introduce expensive new tech.
Right.
But on the flip side, eliminating overuse or misuse of treatments, things people don't actually need, can reduce costs and improve health outcomes at the same time.
Ah, okay. So it's a balancing act.
It's absolutely a balancing act, and it's always subject to, outside policy constraints, like whether there's universal coverage or overall budget limits, and really importantly, always keeping equity in mind. We can't improve things for some at the expense of others.
That makes sense. But this sounds challenging, especially that cost part.
Well, yeah, and this brings us to a really fundamental tension the authors highlight. From a big picture, national perspective, pursuing this triple aim seems essential, right?
Yeah.
It makes total sense.
Logically, yes.
But for the individual players in the system, like a specific hospital or a clinic, it's often not really in their immediate self-interest, financially speaking.
How so?
Think about it. Under the way we usually pay for things now, hospitals often do better financially when their beds are full. They have incentives to expand services, maybe build a new wing to protect their revenue.
Right, keep the machine running.
Exactly. Even if that leads to higher overall costs for the system without necessarily improving quality proportionally. And issues like those CHF readmissions. A hospital might see that as happening after the patient leaves, so
Yeah.
kind of outside their direct responsibility.
I see. So what's rational for the hospital? Fill the beds, make money isn't necessarily rational for the whole system or for the patient who keeps getting readmitted.
Precisely. It's that conflict between individual rational interests and the rational common interest.
That's fascinating. Is there a term for that?
The source beautifully frames it as a tragedy of the commons,
Yeah.
where everyone acting in their own perceived best interest ends up depleting a shared resource, or in this case, driving up costs and fragmenting care.
A healthcare tragedy of the commons. Wow.
And the point isn't to say the hospitals or doctors are irrational or bad actors. They're responding logically to the incentives they face.
So the challenge isn't to just tell them to be different.
No. The big policy challenge, as the authors put it, is to change what is rational for them to do, to realign the incentives.
Change the rules of the game, basically.
That's it. The article even makes a pretty bold statement that, the holy grail of universal coverage in the United States may remain out of reach unless, through rational collective action, overriding some individual self-interest, we can reduce per capita costs.
So achieving that broader goal might depend on solving this incentive problem first.
It suggests they're deeply intertwined.
And the source mentions other obstacles too, right? Beyond just the misaligned incentives.
Oh, absolutely. It's a complex picture. They list things like supply-driven demand. The idea that just having more specialists or more MRI machines actually creates more demand for those services, whether they're truly needed or not.
Build it and they will come, basically.
Sort of, yeah. Then there's the constant influx of new technologies that might have only marginal benefits but come with huge price tags. Also, a system that's still very physician-centric, maybe not always integrating the whole team or the patient's perspective fully. A general lack of appreciation for, systems thinking, understanding how all the pieces fit together.
Right, back to the silos.
Yeah. And interestingly, they even mentioned the lack of foreign competition. In many industries, global competition forces efficiency and innovation. Healthcare in the U.S. doesn't really have that pressure.
That's a really interesting point. Okay, so we have the goals, the paradoxes, the obstacles. How does the source propose we actually start pursuing this triple aim, given all that?
Well, the authors argue there are 3 essential preconditions, things you absolutely need to have in place to even have a shot at this.
Okay, what are they?
First, you have to recognize a population as the unit of concern. You need a clearly defined group. Maybe it's everyone enrolled in a certain health plan or, all diabetics in Massachusetts, as they suggest, not just whoever walks in the door.
Right, define who you're responsible for.
Exactly. Second, you need externally supplied policy constraints, things like a total budget limit for that population's care, or maybe a requirement for universal coverage within that group, some rules from the outside.
Okay, population, policy constraints, and the third.
The third, and this is really crucial, is the existence of an integrator. some kind of entity, an organization, that formally accepts responsibility for all three: aims, the care experience, the population's health, and the per capita cost for that defined population.
That integrator.
And critically, this integrator cannot be allowed to just exclude the sickest or most expensive members to make its numbers look good. It has to take responsibility for everyone in that defined group.
So this integrator sounds like the key player, the one that could potentially overcome that tragedy of the commons.
That seems to be the idea. It's not just letting market forces sort it out. It's about having a single organization that can actually coordinate or induce coordination among all the different health service suppliers, hospitals, clinics, specialists, home care, to work together as a system for that population.
Can you give examples of what that might look like? Who could be an integrator?
The source gives a few possibilities. It could be a well-established integrated system like Kaiser Permanente, which already combines insurance and care delivery.
That's a familiar example.
Or potentially it could be a really forward-thinking insurance company, or maybe a large primary care group that partners closely with payers, or even a hospital system that decides to take on this broader responsibility, maybe by partnering with payers in a new way.
That sounds like a huge undertaking for any single entity, though. Getting all those different, often competing players to coordinate. Does the source acknowledge how incredibly difficult that would be? Or does it just sort of say, we need an integrator and assume it can magically make coordination happen?
Well, it definitely acknowledges the challenge. I mean,
Yeah.
the whole paper is about how hard this is.
Right.
But the argument is about the necessity of this role if we're serious about the triple aim. Someone has to be accountable for all three parts.
Okay, fair enough. So if we have this integrator, what does it actually do? What are its functions?
The source outlines 5 really crucial functions for an effective integrator. The first one is involving individuals and families in a much deeper way.
How so?
It means moving beyond this old doctor knows best or more care is always better mindset. It's about real transparency, patient education, genuinely shared decision-making, helping patients, especially those managing chronic conditions, navigate the maze of the healthcare system.
So empowering the patient more.
Absolutely. Shifting from patients just passively receiving care to being active participants in their own health journey, advocating for their needs and preferences.
Okay, that makes sense. What's the second function?
The second is the redesign of primary care services and structures, basically strengthening the foundation.
Ah, primary care. That comes up a lot.
It's fundamental. This means really embracing concepts like the medical home, having that long-term relationship with a primary care team that knows you.
Right.
It involves things like shared care plans, much better coordination between your primary doctor and any specialists or hospitals you need to see.
Yeah.
And also innovating how you access care, better scheduling, maybe email or virtual consults, connecting you to community resources, all potentially facilitated by a health record that you, the patient, control or at least have full access to.
Wow, that sounds like a big change from how primary care often works now.
It would be. Imagine your primary care provider truly being the coordinator for all your care.
Yeah, that would be amazing. Okay, so function 1 is patient involvement. 2 is redesign of primary care. What's third?
Third is population health management. This is where we zoom out from the individual again.
Right, looking at the whole group the integrator is responsible for.
Exactly. It means shifting from just reacting when someone gets sick to proactively anticipating and shaping the care needs for the whole population or subgroups within it.
How would they do that?
By deploying resources more strategically. Maybe segmenting the population, identifying people with similar health statuses or socioeconomic needs, definitely increasing preventive efforts, screenings, vaccinations, wellness programs.
So stopping problems before they start or managing them early.
Right. And it could even mean cooperating with public health agencies or government policies on broader societal issues that affect health, like smoking rates, obesity, maybe even violence prevention. Think about that CHF example again. Instead of just reacting to readmissions, proactively monitoring all 100 CHF patients on a doctor's panel, checking in, adjusting meds, providing support.
Proactive health, not just reactive treatment. Got it. What's function 4?
Function 4 gets to the money, a new financial management system. This sounds absolutely critical if we're going to tackle the cost part of the triple aim.
Yeah. How does the source suggest we make the payment structures actually support these goals instead of undermining them like they often do now?
Well, first, it means defining and measuring those per capita costs transparently, making the real cost visible. Maybe even showing total health spending on employee pay stubs, for example.
Ooh, that would get people's attention.
It might. But
Yeah.
crucially, it involves implementing regular yearly initiatives specifically aimed at reducing waste.
Waste? Like what?
Things like rework, medical errors, providing care that isn't backed by good science, unnecessary tests or procedures. The source actually mentions a call to action to identify the 10 most common forms of waste in each medical specialty.
Wow, naming it.
Naming it, measuring it, and actively working to reduce it. This means pushing back against that supply-driven care we talked about, really scrutinizing new technologies or big capital investments, asking tough questions like, okay, would hiring 2 more home outreach nurses actually do more for our population's triple aim goals than buying another expensive machine or hiring another specialist?
Focusing on value, not just volume or shiny objects.
Exactly. Value for the population.
Okay, that's 4 functions. What's the 5th and final one?
The 5th is system integration at the macro level. This is about making sure the whole system works together smoothly and reliably.
What does that look like in practice?
It means ensuring that care everywhere across the system is based on the best evidence and delivered reliably. Providing easy access for all clinicians to up-to-date medical knowledge, maybe through shared electronic records or decision support tools. Using standardized measures to track performance. Basically, the system needs to know its own state. How reliable is our care? Are we following the evidence? What are our actual costs?
So building the learning system, essentially.
A coherent, interconnected system that learns and improves as a whole, yes.
Okay, these 5 functions involving patients, redesigning primary care, population health, financial management, and system integration. That's a pretty comprehensive vision for what this integrator needs to do.
It's a tall order, no doubt.
Now, you might be sitting there thinking, okay, this triple aim, this integrator idea, is this totally new? Has anything like this ever been tried?
That's a great question. And no, the core ideas aren't entirely revolutionary. The source actually points to several historical precedents.
Like what?
Well, think about government-sponsored systems like the Veterans Health Administration, the VHA. They have defined population, a global budget, and aim for integrated care.
Okay, yeah.
Or classic HMOs, health maintenance organizations like Kaiser Permanente, which we mentioned. That was the original idea, right?
Yeah.
Integrate insurance in care delivery to manage health and cost for an enrolled population.
Right, HMOs, they were supposed to be the answer back in the day.
They were. The source also mentions national systems like the NHS in the UK, and even some examples of large U.S. employers who got so fed up with rising costs and maybe inconsistent quality that they created their own dedicated care systems for their employees, like Quadgraphics did with QuadMed.
So the concept isn't entirely alien. We've seen attempts. Which brings up the HMO question again. If they were intended to be integrators, what went wrong? Why didn't they fully achieve the triple aim?
Yeah, the source dives into that, suggests a few key problems. One was that HMOs often became defined more by their specific organizational structure, like you had to go to their doctors rather than by the triple aim goals themselves.
The structure became the focus, not the outcome.
Kind of. And often, the patient experience didn't improve enough, or the restrictions on choice felt too limiting and were really unpopular.
I remember people complaining about that. Yeah, gatekeepers and narrow networks.
Exactly. Plus, they ended up competing against traditional indemnity insurers, the ones who mostly just pay claims who were seen as just managing money, not care. It was an uneven playing field. The source also suggests HMOs might have overestimated how much money they could save purely through prevention, which takes a long time to pay off. And they were operating in an environment where providers, not the HMOs, still largely controlled the demand for services.
So a combination of factors kind of derailed the original vision for many HMOs.
It seems so. But, and this is important, despite those past pitfalls, the source is actually quite optimistic about the prospects for integrated care today.
Oh, why now?
Because we have tools and technologies now that were basically unimaginable when HMOs first emerged in the 70s and 80s. Things like sophisticated electronic health records, telehealth, instant communication, data analytics. These make virtual integration and coordination much more feasible than they used to be.
So technology could be a game changer this time around.
It could certainly help enable it. Plus, we're seeing innovations in how we pay for care. The source mentions experiments by CMS, that's the Centers for Medicare and Medicaid Services, with things like bundled payments for managing chronic diseases.
Bundled pay?
Yeah, where instead of paying for each individual service, a provider gets a single bundled payment for managing a patient's entire episode of care, say, for a hip replacement, or managing diabetes for a year. That encourages coordination and efficiency.
Ah, okay. So payment reform is also helping.
It seems to be pushing things in the right direction, encouraging that integrated behavior without necessarily needing the rigid top-down management structure of some older HMO models.
Okay, so we've got the problem, the definition of the triple aim, the integrator concept, historical context, and now some reasons for optimism. This all leads us back to what do we need to do to really move forward?
Right, because the source is pretty blunt. It says the current, often destructive behavior, the fragmentation, the waste, is an inevitable consequence of the current rules.
The rules of the game again.
Exactly. So if we want different results, different behavior, we absolutely need new rules, new financing, and new competitive dynamics.
So what specific changes does the source suggest would really accelerate progress towards the triple aim? What should governments or payers be doing?
The authors point to 5 key areas. First, implementing global budget caps on total healthcare spending for defined populations. Basically, putting a ceiling on how much can be spent overall.
Okay, a budget.
Second, establishing fixed accountability for the health status of those populations, making the integrator truly responsible for whether the group is getting healthier or not.
So measuring outcomes, not just services.
Precisely. Third, improving and making transparent, standardized measures of both care quality and costs. We need to be able to see how everyone is doing, clearly and consistently.
Makes sense. Can't manage what you don't measure.
Fourth, sharing the financial gains. If an integrator succeeds in reducing costs while maintaining or improving quality, they should share in those savings. That creates a powerful incentive.
Right, reward the desired behavior.
And fifth, changes in professional education and accreditation. Making sure that doctors, nurses, and other clinicians are actually trained in how to work in teams and how to improve care processes and systems, not just diagnose and treat individual patients.
Building the skills needed for this new way of working.
Yes. And interestingly, the authors explicitly note that a single-payer system would actually be the simplest way to establish many of these conditions: the defined population, the budget constraints, the accountability.
Oh, okay. They put that out there as the simplest structural path.
They do, while acknowledging the political challenges, of course.
Right. Okay, so to kind of bring this all together, the source offers a really neat way to think about whether we're actually making progress. They call it the triple aim test.
Ah, yes, the test. It's quite revealing.
Yeah, it's 3 simple-sounding conditions. First, you'll know you're on the right track when hospitals are actually trying to be emptier, when they celebrate being less needed by the population because people are healthier.
That's a radical shift in thinking for a hospital, isn't it?
Totally. Second condition. Supply-driven care is no longer the dominant force. Instead, patients pull the resources they need, rather than having services constantly pushed onto them.
Patient demand drives the system, not provider supply.
Exactly. And the third condition is maybe the most personal. Patients should be able to say, they remember me. The system is mindful of their individual needs, their preferences, their history, and maybe even mindful of how they could be using their own money for things other than unnecessary medical care.
They remember me. That really captures the experience goal, doesn't it?
It really does. So if you pull all of this together, what does it really mean for you listening to this?
I think it means that better healthcare, care that's more compassionate, truly effective, and actually affordable. It isn't just some impossible pipe dream.
No, the argument here is that it's actually a solvable problem. The framework exists.
The path is there, even if it's difficult.
Right. And that leads back to that final, really powerful assertion from the source that we started with. The barriers to actually achieving this triple aim, they're no longer fundamental technical. We know how to do much of this.
The barriers are political. The barriers are political. The authors state pretty clearly that the superiority of this possible end state, better care, better health, lower cost, is really no longer scientifically debatable.
Wow. So the science is settled, but the politics aren't.
That's the crux of it, according to Berwick, Nolan, and Whittington.
Okay, so let's end with this thought then, building on that political barrier. The source talks about the pain of the transition state, the disruption this would cause to existing institutions, ingrained habits, maybe even income streams for some. If that pain, that resistance to change, is truly what's holding us back from these potentially enormous gains in care, health, and cost, what role do you think each of us as patients, as citizens, as voters might play in navigating that tricky transition?
That's the question, isn't it? How do we collectively manage that transition pain to get to a better place?
Something to definitely think about.